Oh, somebody else is on camera. You over to check your settings because some of you are appearing on camera. Oh, you got off kind of quick too. It's all right. I wonder, is it this laptop? I'm just gonna try another one. That's what it seems like I'm doing lately, is trying different laptops. It's ridiculous. Let's see, new WebEx. I'm gonna see if it allows me to do, let's see. No, that one is a no-go. Delete that one and do a quick launch. Yeah, it's possible the system can be down. I guess I better get a hold of these folks. Sheesh. Thank God for an alternative. I think I still might have my Zoom account. So while we're waiting, God darn it, I got quite a bit to go over today. Some of this I'm going to leave up to you guys to go through because quite a bit of it comes from fundamentals, some from pharmacology as well. You'll see what I mean, but it's not that complex. You know, it's like how do you give medications through your G tubes and you know, how to manage your GJ tubes, your TPN and what have you. There's a part that I really want to get to, and that's why I was going to allow you all to look at some of that information on your own. Of course, I can do like a brief overview of it, but believe me, it's not that difficult. You know, it's like making sure you, when you're using an NG tube, that you grind the medication down to a fine powder so that it doesn't clog the tube, you know, things like that. But if you have viscous medications, you know, medications that are kind of thick, like the, what is that, lactulose? Lactulose can be pretty thick. And so you put it in some warm water, you know, to make it less viscous, and that way it can go down a whole lot easier. So yeah, so it's not really all that much, not all that complicated. So let me go ahead and I think everybody is pretty much on for the most part. I hope the rest of them got my message. All right, so again, I apologize. There may be an outage that I didn't know anything about. All right, so let me go ahead and share my desktop. I have to make sure I'm looking at this right. All right, so you guys should be able to see my nutrition, GI, endocrine PowerPoint, hopefully. All right. So let me show you what I have here so far, and then that way you'll realize this is not that complicated. I usually like to save some lectures to the more complex topics, and there are others, you know, it's just a matter of just reading it. And hopefully you all by this time are used to, you know, my mantra about reading. All right, so this is the PowerPoint on somebody else. People are waiting in the lobby. All right, let me let these folks in. That's Mr. Robinson. When am I missing anyone else? Sorry, I had to unshare in order to let you all in. And by the way, well, I mean, you all did way better than I expected yesterday. Dr. Garcia, who's the regional dean or the dean of this particular alliance. I think Florida, states like Florida and Michigan are in the same alliance, which is why I'm teaching this class. But she wanted to get you all's results because I don't know how well. Well, let me put it this way. The other class seems to be struggling quite a bit, but you all seem to come through extremely well. Real quickly, can you all tell me what do you think contributed to your success on this CMS yesterday?
No sleep.
Really? Now, the review I gave, did you all look at that?
Yes.
And what about the review from National?
Yes. I did the PowerPoint, the voiceover, everything.
So you guys think that
Yes.
contributed to your success?
That, and also for myself, going over the practice assessment A and B helped a lot.
Oh, that's good. And see, that's a great point because sometimes people just kind of blow that off. And I tell them, you need to make sure you work on those because that's going to tell you where your weaknesses are that you can work on. So that's a great point. So, you know, hopefully you all are listening to that. That's a very important point. So you folks are saying something.
And I also thought, as far as the CMS goes, I thought it was a very fair exam. Like most of the questions, you could, or at least I could, pick out the question that seemed the most right.
Right.
It was
Right.
a wide variety of topics, and it was like, oh, you can make a pretty well educated guess that this is the right answer.
Right.
Beautiful.
That process of elimination, excuse me,
Yeah.
that you talked about. You know,
Right.
you look at the answers and go, yes, that would work. No, that wouldn't work. That kind of thing.
Interesting. Well, darlings, you all blew it out of the water. I mean, I felt like I was in the twilight zone. You know, I've never seen it before. I've never seen that kind of performance before. So, hey, kudos to
Well,
everyone.
good job to you too.
Well, I appreciate it, but you know, unless you all put in the work, it means nothing. I can sit here, you know, all day, every day, and but you guys really jammed it up. So, yeah, that's people were saying, said, well, what are we doing wrong, you know, here locally? So, but in a class like this, it does really help you with a lot of your critical thinking because I'm sure you all can attest to the fact that at this point in time, you realize that what you have been studying before compared to this class, you have to delve a whole lot more deeper. You know, it's not that a surface kind of learning, if you will, because it's critical care. You know what I mean? And so, but at any rate, I'm really happy for you all. To be quite frank, if you guys, well, even if you didn't do as great on the CMS, once you do that binder assignment, that's going to kind of like pull that grade up a bit more because those two are kind of connected in a way, right? And then, of course, if you do well enough on your final exam, exam 2, truthfully, nobody should fail this class this term. Everybody should be able to go forward, you know. So If you blow off the exam tube, then that's a problem. But if you are serious about continuing to be serious about what you're doing, you shouldn't have a problem. All right. So so hang in there. We only got a few more days, and we can put this one in the books. All right. So let me share again. I used to pretty much have the same level of success with my students at this other school I taught at. We would go through a lot of the concepts and whatnot, and you always the thing you guys have to keep in mind is no matter how complicated this thing is, whatever we discuss, the different topics, you have to always just think about what is my job as the nurse. What is my responsibility here? For example, we'll be talking about Addison's disease, Cushing's disease, which are two opposite, they're both involving the same impaired organ, but they have opposite effects. And so we'll get into some technical kind of complex areas, but then I'll hopefully begin to show you, well, what your responsibility is, for that information. So, and you'll see what I mean when I get there. I'm kind of almost panicking because I lost so much time. But anyway, all right. So check out this. This is slide 1, of course. So make sure you guys are reading this information regarding nutrition and whatnot. Very simple, those are your objectives there. This is just a GJ tube, all right? This is the G tube here, the gastrostomy tube. Sometimes they have a GJ. Sometimes they just have just a gastrostomy tube. But the GJ is basically you're decompressing the stomach with the G tube here. And then this one is where you're actually feeding the patient directly into the gut, right? The jejunum, all right? And that's all that is. And we feed patients. Enteral feedings can start within 24 hours after surgically placed gastrostomy or jejunostomy, 2 without waiting for flatus or bowel movement. So all that stuff is pretty simple. So let's not make it rocket science, right? This is your NG tube, of course, so you guys should be fairly familiar with these tubes by now. Take a look at this table here. Just tells us about how to, administer medications through your tube. So again, this is not rocket science. Like, for example, if using tablets, crush drugs to a fine powder and dissolve in water to avoid clogging, bleeding tubes. I'm not going to sit here and reteach this stuff to you all because you all know this stuff already, right? Let's see. Do refer to chapter. Oh, yeah. Do refer to chapter 39. There is a table here, and it gives you some points of reference to look at. Oh, let me say this to you all. Well, let me ask. I don't know if I can see you all's response on this one, so you all may have to say something. All right, let me ask you all this quickly. If let's say, so we know that Tylenol comes in a liquid form, but it can also come in a pill form, also IV, but I'm more particularly talking about what you give by mouth. So the doctor orders 650 milligrams of Tylenol, right? And the patient has an NG tube. And you have the pills in your Pyxis. Do you need to get an order to change it from the pill to the elixir type?
Yes.
Technically, you really don't. And I'll tell you why. It's still by mouth, right? It's still a pill medication. Now, check your policy, but in our institution, so that's what I'll say with that. So maybe where you guys work. But as long as it's by mouth, you're not changing the route. Somebody else is trying to get in. Oh, y'all. Come on. All right, that's all right. Yeah, as long as it's by mouth, you don't have to change it. And I tell you, it will save your tubes if you do get an order, get the elixir type. Just like with like potassium. Potassium is a pill, but it can also come in a liquid form. And so as long as it's still by mouth, then you're not violating anything. That's why this thing is like that. Oh, there it is. Yeah, so again, just check your policy, but you typically don't have to worry about that, because you can actually just get on the phone and call pharmacy and say, hey, can you send a liquid preparation of this medication, and they can do it without even calling the doctor. And I know things change and things are different wherever you are. So again, check your agency policy. All right, so let's see, that's slide 4, slide 5. Again, we're dealing with, and I actually posed this question here, and we're dealing with how to flush or flushing your tubing. This is very important here. Use sterile water in immunocompromised and critically ill patients. Instead of like tap water, you want to use sterile water instead, right? You always want to flush medications in between, which I never really quite understood that. I know in fundamentals, you guys were taught you get one medication at a time, but you flush in between. But here's my thing, because what they want to find out is the patient having a reaction. You won't know if you put them all together, then you don't know which medication caused the reaction. But here's the thing, even though you, let's say I give medication 1, flush, give medication 2, it's not like I'm waiting 30 minutes between flushes. I'm giving them one after the other, so they all will end up in the stomach. So maybe somebody can give me another explanation that makes sense to me, then I'll change my stance on it. But it kind of doesn't make any sense to me. Of course, when you go into the hospital, you'll see that it gets all crushed together. Now, for state boards, for your testing and so forth, I have to tell you, you need to flush in between one by one. Give a one by one, flush in between. So I'll leave it at that. You know, save my license. See, flush, clog, too. Yeah, so all this stuff, I mean, all this stuff is pretty simple. All right. And then with the parenteral nutrition, I provided some pretty good information here for you all. One of the things you all will make note here is, I don't know if you all have had a chance to set up a TPN, because some hospitals set it up, well, the hospital I was at, and for years actually, different hospitals, they didn't administer or hang the new bag until like 8 o'clock at night. When I was at Shands, Jacksonville, they hung theirs about 6 o'clock in the evening, which meant that my students had a chance to hang it. So, and it can be a bit convoluted, the way they, have to do all the connections and, you have the tubing and the filters and those kinds of things. But one of the things I really want you to also to understand about parental nutrition is that depending on the glucose contents, if the glucose contents is low, then you can use a peripheral line to infuse the TPN. But if you ever read on the bag, and you need to make sure you hear what I'm saying, when you read the bag and it says central line only, that is because that is your central TPN. The glucose contents are much higher. Let's see if I got it here. Yeah. So with central peripheral TPN, the high glucose contents is 20 to 50%, or it measures 1,600, I guess that's millimoles or whatnot. But if you try to infuse this central line with this hypertonic, it's very hypertonic contents into a peripheral line, it will cause irritation and also thrombophlebitis. All right. So if you only have a peripheral line, IV line, but the TPN says central line only, do not give it. The physician will either have to come up and put in the central line, or they'll have to change it to PPN or peripheral hyperal. So there's two types: peripheral peripheral hyperaldosteronism and central hyperaldosteronism. And they'll likely have to come up and actually put in a central line because they give central hyperaldosteronism for a reason. And it is because when some patients have really high caloric needs, then they need central hyperaldosteronism. If they're only going to be on PPN for a short period of time, or if this nutritional support is needed for a short period of time, then PPN is appropriate. So, and also right here, it talks about if you hang TPN without lipids, you use this particular micron filter. If let's see. Yeah. So if you don't have the fat emulsion or what we call lipids, then you can use this particular filter. Otherwise, you have to use this filter. All right, and that captures those particles that you find in TPN. So keep that in mind too. Also, we actually add insulin to TPN. All right, we actually add it to the TPN. Because it helps to keep the blood glucose levels under control. So what else can I tell you? You all know about labeling, tubing, the time and date, your initials, and all that stuff. Now this is very important. If a I said I wasn't gonna go through all this, and I'm trying not to, but I have to depend on you to read this. If you have a multi-lumen catheter, you always want to dedicate one line to your TPN and don't use it for nothing else. If it's for TPN, it's for TPN. Only if it's absolutely necessary that you will use it. But again, only if absolutely necessary. Otherwise, just that TPN line should just be for TPN. If you do have to use the line, you have to flush it very well. Let's say you have to flush it with 10 cc's of normal saline, and you got to pull back a waste. Depending if the patient's H&H is pretty low, I would probably, once I toss that waste, I'll go ahead and withdraw my lab sample and then send that off. But if the patient's H&H is pretty stable for the most part, I'll probably get me maybe like a full waste and then maybe a half waste. And then I'll go ahead and draw the full lab sample just to make sure. And you'll know if you drew blood that has the TPN fluids in it, because your electrolyte labs will be way off. So you will know. All right, so those are some things to consider. Here, these are some of the complications of parenteral nutrition. And so take a look at this information that I provided for you here. These are some of the metabolic problems that you'll have, the refeeding syndrome, which, let's see, I talk about here, how you can recognize refeeding syndrome. And also it can cause problems with, let's say, hyperglycemia, hypoglycemia. Think about the fact that if the patient, if the line stops working and then you don't hang D10, the blood glucose levels will plummet on you. So, and of course, with TPN, with the glucose contents, it can cause hyperglycemia. One thing you would note in my notes about TPN is that we have to give the patient glucose and lipids so that it can be used for fuel. The body can use it rather for fuel, because what we're trying to do is spare the amino acids, which amino acids are the building blocks of proteins. And we need proteins for what? Wound healing and what have you. All right. So the glucose and the lipids are just to, it allows the body access to an available fuel source, and again, because we're trying to spare the amino acids, we need the amino acids to help the patient to heal. And then these are some of the catheter-related problems. So just take a look at that. I mean, this is pretty much self-explanatory, especially the pneumothorax, hemothorax, hydrothorax. You're trying to, insert this line, And of course, you know, you can, what's the word I want to use? You can, I don't want to say stab the lungs. There's another word I want to use, but the needle that you used, that the physicians use to put in the central line, especially when it's a subclavian line, it can puncture the lung. That's what I guess I want to say. It can puncture the lungs, causing a pneumothorax. You know, kind of lost for words on that one. Uh-oh, it moved. All right. Really, there's a section that I just really need to get to. Now, look at this refeeding syndrome here. I think I'm testing you on this one as well. But hypophosphatemia is the hallmark of refeeding syndrome. All right. And that's basically what? Low phosphate levels. All right. And look at some of the issues that the patient may have. All right. Cardiac dysrhythmias, respiratory arrest, and neurological disturbances. So it's just telling you how it affects the cardiovascular, the respiratory, as well as the neurological system. Check this one out. Conditions that predispose patients to refeeding syndrome include long-standing malnutrition states. So if a patient has been malnourished for a pretty long period of time, then yeah, they can, you know, when you are giving the patient TPN, they can develop this refeeding syndrome. For example, chronic alcoholism, vomiting, diarrhea, chemotherapy, and major surgery. When you have these types of patients and then you start feeding them with TPN, they can develop this refeeding syndrome. Take a look at so it's characterized by fluid retention and electrolyte imbalances. And so not only the phosphate levels are low, but the potassium and the magnesium levels are low as well. So again, just take a look at that. All right. And this is some other information that I provided for you all to take a look at. It's just basically, much of it is, well, some of the general surgery things, especially if patients have NG tubes, some of the complications, if you will. Let's see, what time is it? All right, so as you can see what I've written here, no matter what the cause of the GI disorder, if there is a GI disorder, then we know that nutritional deficit might become a problem for these patients. When you think about some of these issues such as peptic ulcer disease, which I understand was on your CMS as well. One of the biggest problems with peptic ulcer disease is that the ulcer may go all the way down to the blood supply for the stomach, and that could cause, of course, a hemorrhage. All right. Let's see. What can I tell you about this? So some of the complications to look for: hemorrhage, perforation. So look for that hard, rigid abdomen, shock, anorexia, nausea, vomiting, unstable vital signs. So just basically signs and symptoms of shock for the most part. Let's see, surgical interventions can vary, as well as post-op care. So really important, I have this in red, an NG tube, you do not manipulate right after surgery. The NG tube, of course, we're providing in order to decompress the stomach. You know, so the stomach, during surgery, when those bowels go to sleep, the abdomen can tend to, these patients develop a lot of flatus and whatnot. And of course, the NG tube will help to relieve the patient of all the gas that is being created. You know, because the more gas in the stomach, and the stomach grows more and more, it places more pressure on those sutures. And so we put in an NG tube so that we can decrease that pressure, so that we don't compromise our sutures. Let's see. So here we talk about well, we're measuring the drainage, and we're looking for possibly bright red blood that needs to be reported to the physician. And we talk about small volumes of bloody drainage from the NG can be expected for the first 2 to 3 hours because there's some bleeding at the anastomotic site. So that's pretty common. But if you get bright red blood, then that's a problem, and it does need to be reported to the physician ASAP, or stat really. And of course, you're looking for your electrolyte issues, acid-base issues, respiratory problems. This is all post-op stuff that you guys pretty much already know. So anyway, make sure you take a look at this information. Again, pretty self-explanatory, the information I provided for you. Dumping syndrome, you're going to see this again next week. All right, so take a look at it, see what it's all about. All right, let's see. So, all right, so right here is what I want you to focus on as well. So dumping syndrome, direct result of surgical removal of a large part of the stomach, as well as the pyloric sphincter. And of course, with the pyloric sphincter is the first part of the small intestine before you actually get to the duodenum or duodenum, however way you want to pronounce it. And of course, let's say if somebody has bariatric surgery, when they were trying to, that weight loss surgery, you're removing these structures. And of course, you know how when you eat, food remains in your stomach for a certain period of time before it slowly moves, we call it chyme, before it slowly moves from the stomach and into the small intestine, the duodenum or duodenum, right? And I did explain that here. Normally, gastric chyme enters the small intestine in small amounts. That's that food. Once the food is all chopped up and broken down and all that, it's called chyme, and it enters into the enters into the small intestine. So after surgery, the stomach no longer has control over the amount of gastric chyme because we pretty much reduced it by cutting it away. Entering into the small intestine. So therefore, this large bolus of hypertonic fluid enters the intestine, right? So when that food is broken down, that chyme is more hypertonic than anything else. And when that hypertonic fluid enters into the intestine and into the small intestine, what it does is it creates this creates a decrease in plasma volume, right? So what that means is, so in our plasma volume, the intravascular system, right? So we have so much volume, but if the chyme in the small intestine is very hypertonic, it has a pulling effect on the volume in the vascular space, and so it'll pull a lot of that volume out of the vascular space, right? Because it's hypertonic. It's kind of like if somebody has cerebral edema, right? We give them a hypertonic solution like mannitol, and it pulls that fluid out of the cells. Well, when this fluid, this hypertonic chyme enters the small intestine, it also pulls a lot of fluid from the intravascular space. And we know that when it does that, right, then these patients are going to experience, what we have here. Let's see. So they have this general feelings of weakness, sweating, palpitations, dizziness. And this is because the intravascular space, that first space, it has been reduced. Again, because that chyme is so hypertonic, it pulls a lot of those fluids out of the intravascular space. And so that's what happens here. And it happens 15 to 30 minutes after eating. I believe, if I'm not mistaken, if I can remember my reading correctly, one of the things they teach these patients in order to avoid this issue is, as soon as they eat, they tell them to lie down, and that slows down that transient. The foods, the chyme moving from the from that small part of the stomach into the duodenum, right? So I don't know if I saw that in your textbook, but I'm pretty sure it's in my other textbook. So, you know, different sources, they give you a little more information. So these are your symptoms here. So make sure you take a look at that. These patients have abdominal cramps, and this bora bugami or something like that. Actually, you know, try to spell it out. All right. So, and what this means is audible abdominal sounds made by hyperactive intestinal peristalsis. So you hear this a lot of bowel sounds, increased bowel sounds. That is as a result of intestinal peristalsis, and also an urge to defecate as well. See, these manifestations usually last 1 hour after eating. A short rest period after each meal reduces the chance of dumping syndrome. And I think that's what it's talking about when I mentioned that, you know, you have to tell your patients to lie down. That'll kind of slow it down because you're resting the bowels. So anyhow, so just make sure you read that. I'm just kind of giving you the gist of what you know, dumping syndrome is. And again, you get these symptoms because, you know, you're reducing your intravascular volume, and so it's kind of almost like it's a fluid volume deficit. Put it that way. So yeah, so just keep that in mind. All right, so the part I really wanted to begin to get to, try to keep this as simple as possible. All right. So I was sitting you on break about 10 o'clock since we got started late. If somebody tell me they want to go now, just yell it out now. We'll go now. Otherwise, I would send you about 10 o'clock. So feel free to yell out, right? All right. So you guys have already had hyper and hypothyroidism. You know, I should have kind of flipped that around, but maybe not based on this image. All right. So we know that when someone has hyperthyroidism, they have a lot of circulating thyroid hormones, right? And on the other hand, the opposite of that is hypothyroidism, where they have a whole lot less thyroid hormone in the body. All right. When someone has hyperthyroidism, the complication that we think of is what? Thyrotoxicosis. All right. And on the other hand, with hypothyroidism, especially people who have undertreated hypothyroidism, they develop a condition called myxedema coma. With both of these conditions, actually, it can lead to respiratory failure. So both are can be a really big problem. Where you read here, where it talks about euthyroid, this is a normal thyroid hormones. All right, and this is what we're trying to achieve. So if somebody's on the high side, we give certain medications, sometimes possibly even surgery, to try to get them back to a euthyroid state. Of course, if they have to remove the thyroid, then we have to give them, um, um, for example, Synthroid, in order to get their levels back up to a euthyroid or normal state. With the hypothyroidism, of course, we give the patient Synthroid, hoping to get them again back to this state here. All right. And as you can see here, I did provide you with some information about this condition. So for example, let's see. All right. So as you look at this image, what we're talking about, these two extremes, hyperthyroidism and hypothyroidism. And with hypothyroidism, it can lead to this medical emergency of thyrotoxicosis. And the other extreme, of course, it can lead to myxedema coma. I explained all that. And we talked about the euthyroid or normal thyroid, you know, for both of these. All right, so if someone has hyperthyroidism, they might require treatment as far as, for example, PTU is one form of treatment, as well as removing the thyroid gland. All right. Now, the problem with removing the thyroid gland is that the parathyroid actually sets. All right, so the thyroid. Well, let me show you guys. It's better to show than try to explain. Let's see. So thyroid and parathyroid. Hopefully, I'll get a good picture to show you. Oh, come on. For some reason, my Firefox does not work very well. Let me try. Yeah, I don't know about that one. All right, can you guys see my thyroid gland here? Well, you don't see it now, but I just. All right, so you all see that. All right, there it is. Well, that's kind of little. All right, y'all see that now. I made it bigger, by the way. So, so this is actually the back of the thyroid gland, right? So, Rob, you can see that here, the back view. So think about this: if you kind of put your, you know how when you're at some of these theme parks and you put your head through a hole, but like put your neck, I suppose, the anterior portion of your neck, right up against this thyroid gland, right? And so the parathyroid gland sits right in the back or posterior, to the thyroid gland. And if you remove the thyroid gland because of hyperthyroidism, then you'll likely remove the parathyroid glands as well. Hopefully that makes sense. When we palpate the thyroid gland, we cannot palpate the parathyroid glands again because it sits in the back. All right. But we can palpate the thyroid gland, obviously. All right, so that's just to give you an idea about that. Now, this mess here. All right, and so the problem with that is when the parathyroid gland is inadvertently removed, remember the parathyroid gland handles calcium and phosphate levels. All right. Um, so just keep that in mind that these patients can have calcium phosphate issues. So we have to check their labs and then give them replacements as a result. And also think about the fact that if you remove the parathyroid gland along with the thyroid gland, the calcium levels are very low, then we think about those signs of a hypocalcemia, the paresthesia, the tetany. We do these tests like the Trousseau and the Chabot sign just to check to see if there is low calcium. Of course, we'll get labs as well. So that's what that talks about. And also think about if you're having surgery on the neck, inflammation is possible. All right, if that's the case, then if it swells, then we have an obstruction. So think about those things following surgery. You always want to palpate in the back of the neck to see if blood is draining from the anterior or the surgical site down in the back. You may not see blood anteriorly, but it could have pooled in the back of the neck for your patient. So you need to make sure you assess for that. All right, 10 o'clock, come on back at 10:10. All right, class, let's go ahead and get started again. It's 10:10. I hate the fact that I lost my 20 minutes or so messing around with this mess. All right. So let's continue our discussion about hypothyroidism and really with this particular disorder, disorders, if you will. We're mostly talking about the complications because you guys have talked about, again, or you should have talked about in previous med-surg courses, hypothyroidism in general. But for complex, we're more interested in the thyroid toxicosis and the myxedema coma. All right, that's what we're mostly concerned with. Of course, other information is necessary to know because we know it leads up to these severe complications. So again, as I mentioned, with myxedema coma, which is the first complication to speak of, or hyperthyroid crisis. So when these patients are poorly treated, or they're not treated at all, then the mortality rate, look at that, 60% mortality rate. That's pretty significant. All right. Again, when we're talking about hypothyroidism, the metabolic system is moving extremely slow, right? As opposed to hyperthyroidism, the metabolic system is moving very fast, right? You're burning a lot of calories. The heart is working very hard in your hyperthyroidism. All right, but now just back to myxedema coma or the complication of hypothyroidism. Some of the issues that occurs with myxedema coma, these patients obviously can go in a coma. There's, again, respiratory failure. They can develop hypotension, hyponatremia, hypothermia, as well as low blood glucose levels. All right. Now, because the metabolism is so slow, as you can see, I have a little arrow here. Because the metabolism is very slow, that it means that, for example, cardiac-wise, the heart is not really working normally like it should, right? Because the metabolism is working very slow, and so what that leads to is a heart muscle that becomes very flabby, right? And because the heart becomes flabby, the also the chamber size of the heart will increase in size. So what this will lead to is a decreased cardiac output, and so we know what else follows. If you have a decreased cardiac output, you're going to have a decrease perfusion and gas exchange to our vital organs and tissues. And so there will be a decreased cellular metabolism that is worsening over time until we can treat these patients more appropriately. So these patients essentially go into organ failure. All right. Other conditions that can cause these events, drugs. Well, drugs is one of the main issues that can cause, this extreme problem. Now, most patients, they will die from respiratory failure. All right, that's pretty much the most common reason. Remember, these patients go into respiratory failure. Because this condition is so severe, we cannot just give the patient a PO Synthroid, but we have to resort to the IV type of preparation because we need to get them back to that euthyroid state as quick as possible. All right.
Professor, I have a question.
Yes.
What would you say is worse, hyper or hypo? or are they the same? As in, like,
Yeah,
they're both
yeah,
bad.
I would probably lean to both of them being, pretty severe. I mean, of course, with the thyroid toxicosis, if you look at some of the symptoms here, I would probably lean more to hyperthyroidism.
Hyper. Okay.
Yeah, I probably would lean towards that, but I mean, both can kill you if it's not treated properly. So that's the problem. And this is why we're trying to achieve what? This euthyroid. Because either extreme, we're talking about death, right? If both of these become undertreated or not treated at all, it will lead to death. So I really want to say both, but the hyperthyroidism is just more extreme because you have all this circulating, thyroid hormone moving about in your body, and you're breaking down these macronutrients like the proteins and the carbohydrates, and the fats and whatnot, and so. Look at, for example, look at the clinical manifestations here when we're talking about thyroid toxicosis. You have the severe tachycardia, which can lead to heart failure, right? And you have this hyperthermia. Look at the temperature here, 106. Agitation, delirium, seizures, abdominal pain, vomiting, diarrhea, and so forth, a coma. So they all both can lead to coma as well. So I mean, what would you say? I mean, I would I would probably lean to hyperthyroidism in this case. Maybe I'll make that one red too. Get you all to really thinking about that one. Yeah. Yeah. So I would probably go with the hyperthyroidism, but it just really depends on where the patient is, how long they've been undertreated, and so um, now typically we do manage thyroid conditions in the community, but when these complications occur, then they need to come to the hospital ASAP, because they will die on you. These patients, as we know, they have the rapid weight loss, increase in appetite. I mean, you can hardly feed these patients enough, and they still burning calories and whatnot. So we have to place these patients on really high calorie diets and whatnot. Now the hallmark for hypothyroidism is heat intolerance, and so these patients, they can be like in very cold weather. I'm talking about like probably Michigan weather, and they'll probably have on like a t-shirt outside or something like that. Of course, now, anytime we're talking about these endocrine disorders like hypo this, hyper that, for example, hyperthyroidism, hypothyroidism, hyperparathyroidism, hypoparathyroidism. If you ever run into a problem, just try to remember one, because the other one is the opposite. Usually I tell people to remember the hypo, and then the other one is the opposite, right? So if there's heat intolerance for hyperthyroidism, then there's going to be cold intolerance for hypothyroidism, meaning you could be in a patient can be in a temperature of 80 degrees, let's say in the house temperature is 80 degrees, and these patients they'll be like a comforter or something. They just really have a lot of layered clothing or whatever because they're cold. The thyroid gland is underperforming severely. All right, so you have the cold intolerance. Also, whereas though you have diarrhea and hyperthyroidism, you're going to have constipation in hypothyroidism. So it's just the opposite, and that's the easiest way to look at that. I actually had another image I wanted to show you all, just in case some of you who were confused about the thyroid system and how it works. All right. So let me know if you guys can see this image here. The hypothalamus and the anterior posterior pituitary gland. Can you all see that? Let me know if you guys can't see this. All right. Uh-oh, I didn't mean to do that. All right. All right. So, yeah. So of course this is the hypothalamus, and of course the pituitary gland, right? And the pituitary gland, of course, is under the influence of the hypothalamus, and so all that just works together, right? So you have the anterior portion of the pituitary gland, and it handles most of your thyroid stimulating hormones, whereas though the posterior part of the thyroid gland, it manages just a very important few, but it does handle a few, as you can see here, these arrows, right? And all right, so this is how it works. Let me just give you some examples. So if there's not enough, let's talk about the thyroid gland, for example. If there's not enough thyroid hormones levels in our body, the anterior portion of the pituitary gland is going to produce or secrete, I should say, TSH, thyroid stimulating hormone. This thyroid stimulating hormone is not the actual hormone. It's just a stimulating hormone. Its job is to stimulate. It will stimulate a distant organ, right? So the anterior portion of the pituitary gland will secrete this thyroid stimulating hormone. And what this hormone will do is travel to the thyroid gland by way of the blood. And so the thyroid stimulating hormone will stimulate the thyroid gland, right? It will stimulate it. It will tell it, hey, you need to produce some thyroid hormone because I'm too low. And so it produces what? Thyroid hormones, right? All right, now let's talk about the posterior portion of the pituitary gland. A patient is urinating a lot, all right, and the body's detecting that, and with help from the hypothalamus, it's detecting that we're excreting too much, let's say urine, right? And so the posterior portion of the pituitary gland will secrete ADH, which is antidiuretic hormone. This hormone will then travel to what? The kidneys. See, that's what makes this system so beautiful, is that you have the pituitary gland way up here, and it has an influence on these distant organs that you can see here. And so again, so this hormone is traveling to the kidneys, and it tells the kidneys to reabsorb its water, all right, because it's anti-diuresis, right? So take a look at another one. All right, so this is the adrenal gland, more specifically the adrenal cortex. So that the anterior portion of the pituitary gland is responsible for that particular hormone. And so when we're thinking about the adrenal cortex and the hormones that it is responsible for, we think about cortisol, aldosterone, and what's the other one? Your androgen type of hormones, right? And so if any of those levels are low, all right, the anterior portion of the pituitary gland is going to produce this stimulating, secrete this stimulating hormone, which again travels from the anterior portion of the pituitary gland by way of the blood to the adrenal cortex. And it will stimulate the adrenal cortex to, let's say, if the body needs cortisol, or if it needs aldosterone. Well, it will make it will cause rather the adrenal cortex, not medulla, because the adrenal gland consists of the medulla, which is more responsible for the catecholamines, like your epinorepinephrine, the sympathetic nervous system. But then the cortex is responsible for those three hormones, the cortisol, the aldosterone, and the androgen type of hormones. So if they are low, all right, so there's a term that we call positive and negative feedback loop. If your numbers are low, then the positive feedback loop, just think about a plus sign, right? Plus signs means we need to what? Add. And so the positive feedback loop, when our levels of hormones are low, it will stimulate or the anterior or portion of the pituitary, even the other one, the other side, the posterior, will secrete these stimulating hormones to cause its distant organs to secrete the necessary hormones. Once we reach a maximum level of that hormone, then the negative feedback loop kicks in, and then we stop. We stop producing that hormone, or that stimulating hormone is no longer necessary until those levels drop again. Does that make sense or not? Or does that not make sense to anyone? I hope I haven't lost you guys. You all still there? Let me make sure I haven't lost you all. All right, you all still there. Is everyone good? Well, y'all may have put something in the chat box that I can't see. All right. All right. So you all listen. Say again.
No, I was saying we're good.
All right. All right. Let me know now, because I want to keep moving, and y'all are like, what the heck did he just say? All right, so that's the pituitary or the endocrine system. So those of you who didn't really quite have a good grasp on it before, hopefully you do now. When I was an LPN, actually, there was a gentleman from the Bahamas, I think, the Bahamas. He actually explained this, well, probably not like this per se, but for the most part, he explained it like this, better than the instructor. So, because I've always thought it was just a very complicated system to understand, but it's not too bad. Let's see, let me share that screen again. All right, so let me go ahead and get rid of this. All right, so now you guys have an idea. So think about that positive negative feedback loop. If it's the positive feedback loop kicks in when you need more, negative feedback loop kicks in when you need to stop. And that's just to keep us in balance, that homeostasis, right? Sometimes we have tumors, right, on pituitary glands, for example, and it just hyper secretes these secretions. And so then these patients have more, such as, let's say, in hyperthyroidism, you have a tumor on the pituitary gland. It can cause hypersecretion of the thyroid stimulating hormone, and so these patients can become they'll experience hyperthyroidism. So it just depends. All right, so take a look at the some of the symptoms that you might see in these patients. Increased bowel movements, appetite is increased because you're burning up everything, unexplained weight loss, but there's weight gain in the hypothyroidism, because you're not really burning. The metabolism is very slow. All right. Let's see. I told you about that. You have all this increasing thyroid hormones. I told you about the symptoms here. And look at the first line drug treatments here. you have the propionthiracil and the tapazole are the drugs. And with these drugs inhibit thyroid hormone synthesis. And so remember how when we get into the mechanism of action for some of your drugs, so this is really good to know, because what it basically does is it stops the thyroid gland itself from producing the hormone. Let's say if you have hyperthyroidism, if I can inhibit, or if I can, prevent the production of thyroid hormone, then I can get my thyroid levels back to normal, because and in this particular context, they're very high. Hyperthyroidism, they're very high. All right, so that's hypothyroidism. Now remember the surgery, you're cutting on the neck, you have obstruction issues, you have bleeding can be an issue. Remember your signs and symptoms. Also remember this too. If somebody's being treated for hypothyroidism, so we already know what the symptoms are, right? Talked about the constipation, the dry skin, and the cold intolerance, and all these things, right? Cardiac issues that we talked about. All right, the heart rate is going to be really low, like bradycardia as opposed to tachycardia. All right, so we give these patients, let's say, Synthroid, right? In about 2-3 weeks or so, we want to see a normal heart rate. We want to see maybe some weight loss. In other words, it's telling us that the medication is working. But let's say the patient comes into your clinic, or they come in the hospital, whatever, and their heart rate when they were there before with hypothyroidism was 55. Now they come to you, their heart rate is 130. What do you think we need to do with that medication? And I can't see your chat, so I don't know how to get this chat thing. Maybe so. Maybe I can get it from there. I don't know how to see the chat for this one other than coming out of this. Well, maybe I can just come out of this. All right, so I don't have anything from y'all. All right, so if the patient has a hypothyroidism and you've been treating them for a few weeks, now their heart rate is 130. Now they have this clammy, moist skin. They have diarrhea now. They have heat intolerance. So now you push them to the opposite direction. So we need to titrate that medication more downward. All right, if that makes sense. We have to titrate it down, because it's now they're on the opposite end. So we always have to titrate again until we can get that euthyroid state. All right, that's the goal. That's what we're trying to achieve. We're trying to achieve euthyroidism. All right, so just keep that in mind, that if a patient's being treated for hypothyroidism, it is possible that they can develop hyperthyroidism because of the medications. All right, and this is why when we're teaching these patients, as far as the education about this disease process, we have to teach them signs and symptoms of both. All right, because if if again with that same scenario, if they develop hyperthyroid symptoms, then they need to be able to understand that and report that as well, so they can come in and have the medications titrated. All right. Any questions? All right. All right, so now this is the one that I really wanted to get to, slide 10, because I think this is one that will probably confuse quite a bit of people. All right, so when we're talking about Addison's disease, Cushing's disease, and I kind of want to talk about these more or less in pairs, although I don't know why I didn't add Maxidine McComey here. But anyway, so for example, these two. we're talking about here, there's a deficiency of adrenal hormones, cortical hormones, and of course there is a hypersecretion of these hormones, right? Now, so I want you to think about this. Let's see, where do I have it? I think it's this one. All right, let me know if you all cannot see my picture of thyroid, excuse me, of an adrenal gland. All right, because I'm tired of drawing. My drawings just don't look too good. Anyway, so this is the adrenal gland. We know that the adrenal gland sits on top of the kidneys, and so this is kind of a, I guess, high level, overview of this is basically anatomy and physiology, but I know it's been about 2 or 3 years. Anyway, so this is the adrenal gland that sits on top of the kidneys, and the adrenal gland has a middle portion, medulla, middle. That's an easy way to, I guess, remember it. And then you have the cortex that surrounds the medulla, right? The medulla produces your catecholamines, such as your epinephrine and your norepi, this is what I'm more concerned about, not so much as that, but the catecholamine. So just remember that. However, when we're talking about the cortex, we're talking about the mineralocorticoids, meaning aldosterone and corticosterone, but more particularly the aldosterone. The glucocorticoids, think about the cortisol, glucose, right? So think about glucose. Then we talk about the androgens, estrogen and testosterone. So now we know we're going to have some male-female issues as well. All right. So that's what I want you to think about. In the case of the mineralocorticoids, more specifically aldosterone, remember the RAS system, RAAS, the aldosterone part. When the RAS system kicks in, aldosterone becomes active, right, from the adrenal gland. And so what the aldosterone does is it causes the kidneys to reabsorb sodium and water follows, right? While I'm talking about that, so let me show you why this is relevant. All right. So let's say if someone had Cushing's disease, and we know that Cushing's means there's this hypersecretion of these hormones, right? Well, let's talk about one at a time. So you got this hypersecretion of hormones, of the mineralocorticoids or aldosterone. So the aldosterone travels to your kidneys, and then it causes it to reabsorb sodium and water. So as far as a symptom for Cushing syndrome, what do you all think your blood pressure would look like? With what I just said,
Can you repeat what you said again? My connection cut out.
all right? So if someone has Cushing's disease, remember we're talking about Cushing's and Addison's disease, so there's just the opposite. With Cushing's disease, we have this hypersecretion of all of these hormones, right? But let's take them one by one. It makes it easier for you guys to look at it one by one. So with the mineralocorticoids, such as aldosterone, think about the RAS system when we talk about the decreased blood flow to the kidneys. In that, when the aldosterone kicks in, and aldosterone will make the kidneys reabsorb sodium and water, right? And so if you absorb sodium and water, tell me what would your blood pressure be with Cushing's disease?
If you're absorbing more sodium and water, your blood pressure is going to be higher.
Exactly. So tell me this. What if you have Addison's disease and you're hyposecreting aldosterone. What would you? And so now you're not making sufficient aldosterone. So sodium in water is what? Excreted, but you are holding on to potassium. So what would your blood pressure be?
It'll be low.
That would make the blood pressure bottom out.
It'd be low. What would your potassium level be?
It would be high, and then that's
High.
going to potentially trigger their heart rate to go up, correct?
Well, it'll cause cardiac dysrhythmias, right?
Yes. Yep.
So we have to place them on a monitor. So it's very important to place these patients on monitors, right? So that's that part of it. So let's go to the glucocorticoids. We know that when we say glucose, we're talking about glucose, right? We need this for stress. If we didn't have enough glucocorticoids, we would die because our bodies cannot, it requires that in order to handle stress. So let's say with Cushing's disease, we're holding on to, we're producing a lot of glucocorticoids, this hypersecretion, right? Because you're producing a lot of ACTH, the adrenal cortical hormones, all right, the ACTH. So you're producing a lot of this in Cushing's disease, it's hypersecretion. What do you guys think your blood glucose levels will look like? Talk to me. Y'all probably saying something in the chat. I can't see that thing. I like WebEx better because I can see what you're saying. I mean, see, maybe you're saying something. All right. I don't have anything yet. So can you guys help me out? Hopefully your connections are good. So if we're talking about Cushing's, this is hypersecretion. And so we're producing a lot of this, right? Glucocorticoids. So what do you think your glucose levels are going to look like? All right. Well, they are going to be high. All right. If you produce if you secrete too much of this hormone, then of course glucose will have to be high. And of course the opposite of that for Addison's disease, we're talking about hypoglycemia. So hyperglycemia with Cushing's, but hypoglycemia with Addison's. All right. All right. Now, if we look at the androgens, all right, that's estrogen and testosterone. If someone has, if you're producing too much of the hormone ACTH, that means that androgens are going to be high as well. And so then you have to start thinking about these secondary sex characteristics in males and females. For example, females may begin to grow hair, right? And all these other different characteristics. They may have their menses might be off. We talk about, well, I'll let you see some of the other different female male characteristics that we talk about. All right, because one of the reasons I'm going this route with you all is that if you can understand the anatomy and physiology piece of this, then you understand what is happening with these endocrine disorders, right? And this is why I'm showing you this image, because I'm showing you what the adrenal cortex, what it actually produces, the aldosterone, the cortisol, the estrogen, testosterone, and then of course not to be confused with the medulla and what it is responsible for, which is the catecholamines. This should help you to understand the disease process itself. So when I go back here, right? All right. So these are some of the things that happen. So the adrenal corticosteroids may decrease. Of course, right now we're talking about hypofunction. So we're looking more at Addison's disease here, right? A deficiency in the secretion of adrenal cortical hormones. So that ACTH, I showed you that. Here. So if we have hypofunction, it means that the anterior portion of the pituitary gland is probably not producing enough ACTH to stimulate the adrenal cortex to produce the necessary hormones. Now, that could be a problem, but it can also be a problem at the tissue level. Maybe the cells of the adrenal cortex are impaired, and they're not getting, maybe let's say enough blood flow, maybe shock or something like that. Or maybe some other issues, cancer or what have you. And so it cannot respond to the stimulating hormones. So it could be any of those issues and whatnot. All right. So it could be those issues. The signs and symptoms, they can occur gradually or quickly, especially with stress. With the adrenal cortical insufficiency, these patients develop what we call an adrenal crisis, right? Which is life-threatening. They're life-threatening signs and symptoms, and sometimes these patients it may come on without warning, so more or less insidious. All right. So when there's the deficient adrenal corticosteroids, then these patients may lose their ability to produce the aldosterone, the cortisol, the androgen type of a hormone. So again, there's this reduction. All right. Remember, I told you I like to usually start with the hypo, and that way you can see what's going on the opposite side. Look at one of the other issues here where I talk about this. If there's a reduction in cortisol levels, then the blood sugars are going to be low. All right. Decreased production of ACTH will lead to a decreased production of cortisol, which will lead to a low blood glucose levels. And there's also a decrease in gastric acid production, right, as well as glomerular filtration that occurs with this condition as well. All right, so what that means is if there's a decrease in glomerular filtration, this is going to cause our BUN to be increased because the kidney's inability to filtrate the urine. And whenever you have a patient with high levels of that blood urea nitrogen or BUN, it causes a patient to have anorexia as well as weight loss. This is just a result of the toxins that are building, right? And that's what's happening. Toxins are building. BUN is a toxin that the body usually gets rid of by way of the urine. But in this case, you're not filtrating, and so it leads to a higher BUN. Here it talks about decreased aldosterone secretion. Remember we talked about the function of aldosterone. So what this leads to is the fact that the kidneys are not going to be able to absorb sodium and water. So sodium and water is excreted instead, and these patients hold on to potassium. So you have this high potassium levels, and you have low sodium levels, and you also have a volume deficit as a result. Now, if you have a volume deficit as a result, you know that this is going to lead to hypovolemia, which means that you're going to have blood pressure problems. So you'll usually see these patients with Addison's disease, they have low blood pressure problems. Again, sodium and water is leaving the body, but you're also holding on to potassium. All right, so that can be a big issue, but it can lead to an electrolyte issue. This is what this is talking about. All right. All right. Now look here where, remember I mentioned, so these patients, as you excrete sodium and water, you hold on to potassium. you hold on to potassium, what's going to happen is usually the potassium the body tries to push the potassium inside the cells, but then the hydrogen ions inside the cells comes out of the cells, right? And when that happens, the patient becomes what? Acidotic. All right. So acidosis is a problem with these patients as well. All right. Now, when we talked about the adrenal androgen levels, remember that picture I showed you, the androgens, the testosterone and estrogen. Here's what happens. And so you have these low levels, and so you're going to have decreased body, axillary, and pubic hair. Especially women, as adrenal produce more androgens in females. So you'll see these male-female sex characteristics. In this case, very little. So they may look, their body may more or less appear that they're underage because they don't have axillary hair and what have you. All right. So the greater the hormone degree of hormone deficiency, the symptoms are going to be, more pronounced, if you will. All right. And again, here I'm still, for the most part, we're still talking about this deficiency in the ACTH hormone, and so. Here, I'm basically talking about that positive and negative feedback loop. That's all I'm talking about here. So when you read this, you won't be confused by the fact that, again, if the levels are very low, then the positive feedback loop kicks in. If the numbers of the levels, the hormone levels are high, then the negative feedback loop kicks in, and so you don't produce any more. All right. Let's see. All right. And I talked about this one here with the increase in potassium levels. So we have to think about the dysrhythmias, which can eventually lead to cardiac arrest. Now, I talk about how we as what I need you guys to do, although I know some of this is really technical, but for example, when I read here about the increasing potassium levels, then as a nurse, you need to be thinking about dysrhythmias. Then, if that's the case, we also need to be thinking about if the potassium level becomes too high, that it's going to lead to cardiac arrest, and we may be coding these patients. As far as decreased sodium levels, we realize that because in this condition, sodium and water is leaving the body, so that these patients, we know they're going to be hypotensive, and just think about all the symptoms that comes along with that, the dizziness and just perfusion problems, and altered cognition or change of mental status. And so these are some of your first indicators of adrenal insufficiency. So no matter how complex this sounds, just think about the problems you're going to see in this patient. Again, the hypotension, the dysrhythmias, and because we know that the potassium is high or the sodium levels are low. And we also think about our acidosis, as I mentioned up here as well, and some of the characteristics that you'll see. So those are the things you need to really be thinking about. And I thought I would miss this. This is also, this part here is one of the reasons why we have to slowly wean a patient from steroids. As you can see here, so here's what happens. When we give a patient a steroid, right? When a patient has synthetic steroids in their system, their adrenal glands stop producing these steroids, right? And so let's say if we have a patient on an 80 milligram dose of Decadron. The reason we slowly wean that medication is as we are weaning the medication, we are allowing the adrenal glands to begin to produce more of its own. So by the time we get down to a low dose of Decadron, your adrenal gland would have produced enough steroids, right, to take over, so that, of course, the body can handle the stress that it needs to. And so this is why we have to decrease it slowly. When someone has a synthetic steroid, the negative feedback loop has kicked in. And so the adrenal gland is not producing anything at that point until we begin to wean. As we wean the synthetic hormone, the adrenal gland produces more of its own. And of course, again, by the time or in the end, we hope that there's enough natural hormones that have been produced so that then you can go ahead and DC the Decadron at that point. So just keep that in mind when your patients are on steroids. That is very important. And of course, if you take a look at the Cushing's disease, this is what this one is: adrenal gland hyperfunction. This one here, hypersecretion of the adrenal cortex or glucocorticoids. All right. Now, I tell you what this is likened to. When you look at this, think about steroids. All right. Because when you give patients steroids, especially if they have a bit more than what they need, it produces similar symptoms. All right. And again, the same applies as far as how this can happen. The anterior portion of the pituitary gland might be producing too much ACTH, right? Or a patient can have maybe a tumor on the adrenal gland that's producing a lot of these hormones. So either one. And again, these symptoms can also occur. All right, I didn't mean to go up there. All right, I'm sorry. I was up at the top. I thought that sounded too similar. Anyway, so but yeah, so it can occur at any level, the pituitary gland as well as the adrenal cortex. It can also involve the hypothalamus as well. But this is where you have the excessive amount of cortisol that is being produced, not by the medulla, but by the cortex. All right. And you're going to, again, see a lot of the same issues. When you look at a patient who's on steroids, take a look at this image here. These are all, and you want to really look at this image here because you're going to see this next week, by the way. This is what these patients will have. And of course, in my notes, I talk about why these symptoms come about. All right. For example, the weight gain. If you are producing too much of this hormone, then it means that you're producing a lot of aldosterone. Let's say you're producing a lot of aldosterone, right? Producing a lot of aldosterone, which causes more sodium and water to be produced, rather to hold on to more sodium and water. And of course, these patients, they gain weight. But also because the glucose levels are so high with these patients, they can gain a lot of weight as well. All right. When you think about the slow wound healing, for example, it's because when glucose levels are so high, our white blood cells don't work very well. And so it sets these patients up for infection risk and what have you. So I kind of jumped there, but just want you to see that image and just think about some of the symptoms that we'll be discussing. All right. All right. I'm going to go ahead and keep going, and because, like I said, we lost so much time and don't have a whole lot. But if you want to go ahead and take a quick break, you can. This is recorded, so I'll send this to you And you can always come back to this if you want to. All right. So anyway, we talk about this hypercorticolism. So we're just creating a lot. We're secreting a lot of the ACTH hormone. All right. All right. And so whenever the body has this excessive amount of glucocorticoids, and it doesn't really matter what the reason is, the metabolism and our body systems are going to be impacted. And based on that picture I just showed you, you can see why. I mean, our whole body systems are just impacted by that. So the reason why you have the characteristic truncal obesity or the buffalo hump, and also the moon face, because you'll see this in, again, patients who are receiving steroids as well, is due to fat redistribution. This is caused by this excessive amount of glucocorticoid steroids. There's also an increased breakdown of protein. Our proteins are broken down by this increased production of hormones, steroid hormones. So if proteins are broken down, what is it going to lead to? Decrease in muscle mass. And then if there's a decrease in muscle mass, these patients are going to be more weaker, right? They're going to be weak, decreased muscle strength. Also, this leads to the skin being thin, and you'll notice this with patients. They may not have a hyperthyroidism, but if they have COPD and they're taking this synthetic steroids, you'll see that they have all these symptoms that I'm talking about right now. They have the thin skin, and the capillaries are fragile, so you see the bruising under the skin. Right? Some of you probably have noticed that in your patients who are on steroids. All right. Here's another thing it does. This condition, it has an effect on our minerals. All right. And so this leads to loss of bone density. And if it leads to loss of bone density, it means that these patients are more susceptible to fractures. All right. So you may see some test questions that talks about, say, if you have to move a patient up in the bed, right? You don't grab these patients by their extremities. You grab the sheet and you pull them up, because if you grab them by their arms and legs, you can actually break their legs and arms. All right, because they're losing so much density because of the effect that hypercortisolism has on the body. All right. Now, check this one out about the immunity. Immunity is also going to be reduced when these corticosteroid levels are increased. Here's what happens. It leads to a decreased production of lymphocytes. We know lymphocytes help us to fight infection. It also shrinks organs that contain lymphocytes, such as our spleen and our lymph nodes. Again, that helps us to fight infection. There's also a reduction in white blood cell cytokine production. So what does it lead to? High risk of infection. What does this mean for you as a nurse? Part of your teaching is when these patients are on steroids, that they should avoid crowds, they should wash their hands, because they are more susceptible to infection, right? All right, so keep that in mind. The androgens, and so, for example, when there's this hypersecretion, you may see acne, hirsutism, or something like that. I can't pronounce that. Hirsutism, or something like that. Anyway, also clitoral hypertrophy as well in women. All right. There's also a disruption in the ovarian hormones. In other words, their hormone levels are going to be off, right? And so there's decreased ovarian production with these patients as well. Production of estrogen and progesterone. And of course, this can result in scant or infrequent menses. So again, this is part of your teaching as well. You have to teach your patients that these are some of the things that they can expect, especially in females. And then here I just talk about the cytokines and what it actually means. It's all a part of the immune system, and which is impacted with Cushing's disease. So remember, when I'm talking about Cushing's disease, I am talking about, that's why that went up. I am talking about hyperfunction of the adrenal gland, or I'm talking about hypercortisolism. It's the same thing, right? Same thing. Just use those terms interchangeably. All right. The next one is, let's see, what is this? All right. The next one is we're talking about diabetes insipidus and SIADH. I think you guys know enough about diabetes insipidus and SIADH, and so we kind of just hit some of the highlight areas. When we're talking about diabetes insipidus, it essentially means that ADH is likely not working like it should, right? And it can be at the pituitary level, but it can also be at the kidney level. When I say the kidney level, I mean that even though the posterior portion of the pituitary gland is producing enough ADH, the kidneys may not be responding to it because whatever the reason is, right? And so if it doesn't respond to ADH, then these patients, then they'll could keep urinating, right? Most of these patients, if they do develop a pituitary issue, it could be because of a tumor, it could be because of surgery, could be because of a head injury or something like that. So those are some of the main ones. These patients can become extremely dehydrated because they're urinating a lot. And so their internal environment becomes very concentrated or more dry. And so their sodium levels appear high because they're concentrated. So the sodium levels are high internally, but if you talk about the urine-specific gravity for urine, it will show more dilution because these patients are excreting lots of fluids, right? So they can become severely dehydrated. Sometimes if these patients can drink fluids, then you hope that they can, that will fix, the dehydration from the excessive urine output. Otherwise, it can lead to severe dehydration and death. So these patients may require some IV fluids and also some medications such as, I think it's, desmopressin or DDAVP. And this is just a synthetic form of vasopressin or the ADH, whereas though it stops the kidneys from excreting so much, but it helps it to reabsorb water. All right. And one of the ways we can determine if it's working is we weigh our patients. If they're losing an excessive amount of fluids, then their weight is going to reduce. And of course, once we give them this medication, if they begin to start gaining weight and the urine output is less, those are things we can look at as far as our evaluation. Another thing that may interfere with ADH is lithium, which you may see as a test question, and declocycline is another drug as well. These also appear on some of these standardized tests as well, or NCLEX. So remember those two. These patients can develop shock, folks. They can develop shock because they're losing so much fluids. The osmolarity internally is very high, but the osmolarity in the urine is very low, or the specific gravity is very low. Again, we give them DDAVP or desmopressin is what we give them. I talk about some of the side effects from this drug: ulceration of the mouth, tight chest tightness rather, for that one. Let's see, monitor IV fluids and as well as intake and output, of course. Remember, if you're giving these patients a desmopressin, one of the problems that can develop is fluid overload, because if they're not urinating as much, and especially if they're getting a lot of fluids, then they can go into fluid overload. So we have to make sure that we are watching their weight, watching their intake and output, watching for signs and symptoms of fluid overload. So we want to weigh these patients, same amount of clothing. If they gain greater than 2.2 pounds, they can develop water and toxicity. So which signs and symptoms for that is persistent headache, acute confusion, and nausea and vomiting. And of course, this is a medical emergency. They should go to the hospital. In the hospital, the nurse must detect dehydration early and maintain hydration. So again, intake and output, urine specific gravity, and daily weights. So I think you all know about these two disorders well enough. Now, the SIADH is basically just the opposite. These patients are essentially holding on to fluids because the kidneys may not be responding to the ADH is working too well in this case because they're not urinating, they're retaining. So if they're retaining more fluids, then the sodium levels are going to be abnormally low as a result. So it would be lower. So sodium levels would be lower, and they're more susceptible to fluid overload. Of course, these patients will have more weight gain. And so those are things that we need to think about with this particular one. The electrolyte disturbances, of course, can be a problem. Now, some of the early signs and symptoms of SIADH is due to fluid retention. There's this dilution of sodium or hyponatremia. And so you look for things like GI disturbances, such as loss of appetite and nausea and vomiting. Look for the weight gain, as I just mentioned. Free water is actually retained without edema. So you won't see edema in these patients, but they will be retaining a lot of free water. Let's see. So with water retention and low sodium, fluid shifts affects the central nervous system. And this is especially when these patients have a sodium level of less than 115. And so look at the signs and symptoms that you can expect. Lethargy, headache, they become hostile, and also a decrease in deep tendon reflexes, right? And because the patient is in volume overload, look at the pulses. They're full and they're bounding as opposed to thready and fast for your fluid volume deficits. The urine osmolarity or urine specific gravity is going to be more concentrated because you're holding on to that free water and producing very little in the urine output. So it's opposite again. The specific gravity is much higher for this one for SIADH, but is actually lower for DI. All right. All right. What else can I tell you? With these patients, they may place them on. Make sure you guys are again reading these notes, but they may place these patients on a fluid restriction, 500 to 1,000 milliliters per 24 hours. Check out some of these dilute tube feedings with saline versus water, right? Because we're trying to give them more sodium. And use saline to also irrigate G tubes. Mixed drugs given per G tube via or with saline, not free water. Because the more free water you add, the more diluted their internal environment becomes. And so we want to make sure we give them. We want to make sure we give them. We want to mix some up with the things that we're doing with saline solutions. In other words. Measuring weight, pretty much the same as we would do for DI. Look at some of the medications here. Vasopressin receptor antagonist, or what we're basically trying to do is block ADH. If we block ADH, people will pee, right? That's all we're doing. Vaptans, such as tolvaptan, and also this conivaptan as well. We give that IV. And these, again, a mechanism of action, vasopressin receptor antagonists. They antagonize, they basically block ADH, and so ADH cannot work on the kidneys. Again, meaning the patients will pee at that point. All right, and then of course this will promote water or fluid losses. So you should see these patients as a kind of evaluation piece, and taking output daily weights. Also, they should be peeing. All right, DI, you won't be peeing as much. So just think about those opposites when you look at these. You can even create like a grid where one is juxtaposed to another. You know, hypo is juxtaposed to hyper, and you can just kind of just map it out like that, so you can see it a whole lot better. Another thing to keep in mind with SIDH is this particular fluid right here. 3%, not 0.3%, but 3% saline. This is very hypertonic solution. They usually give this when patients, when their sodium level falls less than 120. All right, when your sodium levels falls less than 120, seizures, mental status change, restlessness, coma. I mean, it is a medical emergency at that point. So that's why repleting or giving them more sodium, it's paramount. But we really have to be careful with this, because they can become hypernatremic very quickly. All right, so we have to really be careful about how much of this we're giving. We have to really monitor them, in other words. All right. All right, so saline is always better for IV fluids and water solution, because the water can add more dilution to the system. So just keep that in mind. Let's see. These patients, they can develop, they are at risk, especially older patients or patients with renal disease, liver, pulmonary disease. They're more at risk for pulmonary edema and heart failure. So make sure you're monitoring those patients in particular. This is your fluid overload signs and symptoms that can occur. And so look at these signs and symptoms here, right? All right, and because of the fact that these patients have these neurological changes, we want to provide a safe environment for them, especially with these neurological changes. We want to provide a safe environment. So that's another thing that your questions can be about, because you know the background of about these conditions. As far as the nurse is concerned, one of your biggest concerns would be what? A safe environment. And again, as far as the nurse's responsibility, fluid overload would be something that you need to watch for. Hypernatremia is another thing you need to watch for. And you're also watching those sodium levels, because the sodium level may not be at 120, let's say if it's 130, but as this patient, as the condition worsens, then this can drop even more. So, you know, again, these are just things that as a nurse, you need to be watching out for. So the more severe the SIADH is, the more frequent the neural assessment needs to be. And so this will help us to look for trends in this patient's condition. So when you think about safety, bed in low position, side rails up, safety, safety, safety. Don't tell the patient, don't get out of bed. May need to check on the patient more frequently, because especially they have change of mental status, they may be getting out of bed anyway. Now, the DKA and HHS is another one that we have to think about. I'm not sure how much you guys, how well you still remember your diabetes, but these are complications that you might find in type 1 and type 2 diabetes. All right. So with DKA, DKA occurs because the pancreas is typically not producing any insulin at all. So you would typically find it in your type 1 diabetic patients. With type 2, you will find mostly hyperosmolar hyperglycemia syndrome, or HHS. All right. Now, so with DKA, the reason you are producing ketones is because if you do not have any insulin being produced, insulin is like a key. And then you have this cell. The cells have, let's say, like a lock on it. And so what the insulin does is it opens the lock and allows the glucose to go inside of the cell. I don't know if I can show you all an example of that. Let's see. Let me try it like this. Maybe to give me a nice picture. And that never works. Darn it. All right, let me try this. Doesn't seem to like me. Let's see, insulin. Let's see if this will give me a nice little, yeah, that's it. I like that. See what it looks like on this one. So I need to do this instead of trying to draw these things because, you know, my drawings can be a bit atrocious. God damn, now this one will take its time. You kidding me? All right, let's look at this one. Sheesh. All right, so the insulin receptors are likened to a lock on the cell, right? And insulin is like the key. When you don't have enough insulin, then the glucose just run all around the cells. They don't go inside the cell. They just keep circulating extracellularly. All right. And this is why our blood glucose levels are high, because you don't have enough insulin. And so in this case, if you do not have enough, if you don't have any insulin, rather, in type 1 diabetes, the body needs to have fuel. And so what it will begin to do is consume fat, right, for its energy source. When you break down fat, its end product is what? Fatty acid. All right. Because, all right, so when we think about fatty acids, right, diabetic ketoacidosis. So that's how the ketosis develops. The ketosis develops because the fat is being used as a food source. The body is eating itself, basically. All right. The flip side of that is, if we're talking about HHS, the pancreas is producing some insulin. Not a lot, but it is producing some insulin. And so there's enough insulin being produced to open up the lock on the cell and allow some of the glucose inside the cell. And therefore, the glucose, or rather, the body would not eat itself or eat its fat, right? And so you won't develop the ketosis. And this is in your type 2. All right. Does anyone not understand that? All right. Let's see. So one thing I need to tell you, you'll hear sometimes that type 1 diabetes is to DKA and type 2 diabetes is to HHS. For the most part, that's true. However, type 2 diabetics can still develop DKA, right? Why is that? So remember I told you with type 2, you are producing some insulin. All right, and that insulin that is being produced is enough under normal conditions. Under normal conditions, it's producing enough insulin so that your body will not break down its own fat. But let's say if somebody is stressed or they have a severe illness or something like that, the body is going to have an increased requirement for insulin, right? But your pancreas will not be able to produce enough of that, enough of it. And in that case, it will start eating or consuming fat. And therefore, these patients with type 2 diabetes, they can develop DKA also. But typically, your type 1s develop DKA and type 2 develops HHS. With that little caveat that I just gave you, you know, if the insulin requirement is greater and there's not enough insulin from the body to supply what is needed, then it's going to consume our the fat, which will produce ketosis, right? So hopefully you all understand that. Now, the good thing about both of these disease processes, HHS and DKA, is they're treated essentially the same. All right, so that part is pretty easy. So you don't have to worry about that. All right, so let me come out of this one. Does anyone have any questions about this? When we talk about the lock on the cell, it's essentially the insulin receptor. All right, so you have the insulin itself and they attach themselves to the receptor and it opens up the cells. All right, this is the intracellular environment and this is the extracellular environment. This is where glucose when you don't have any insulin. But if you have enough insulin, the glucose goes inside the cell. And by the way, exercise helps cells become more sensitive to insulin. So that's why your diabetic patients, excuse me, they should exercise. All right, so let me get out of that one. All right. So let me see if I can hit some. You'll also something else, so you may more or less run across. The blood glucose levels if you ask yourself the question, why do patients with type 2 diabetes, when they develop the complication of HHS, why is the blood glucose levels higher in them than it is in DKA or type 1 diabetic patients? All right. And so the reason for that is with DK, now typically when someone has type 1 diabetes, they're probably very young, right? So they're probably very young. Because they're very young, their kidneys, their heart is still working fairly well, right? And so when they go into DKA, they're still able to excrete a lot of urine with the glucose, right? Their heart is pumping really well, and they're perfusing their kidneys, and they're able to excrete a lot of the glucose, and so their blood glucose levels are going to be lower. However, with HHS, usually these patients are over 60 years of age, and if they've had diabetes for a minute, their kidney is not working as well. They may be in some type of type 1, type 2 kidney disease. Their heart is also impaired because, again, you're 60 years old. And so, you sustain a little damage over the years. So these patients are not able to perfuse their kidneys as well. And so therefore, they cannot excrete the glucose as well. So their glucose levels are going to be much higher in your HHS. All right, so keep that in mind. All right, let me go back. Let's see, DKA. All right, so there's this profound deficiency in insulin here. You have hyperglycemia, the ketosis, the acidosis. Again, the acidosis. What happens is these patients, they develop increased potassium levels as well, and the hydrogen ions will come out of the cells in the extracellular space, and then the potassium would try to, or the body will move the potassium inside the cell. So these patients, they become acidotic as well. They become severely dehydrated because, the glucose contents is very high in the extracellular space. And so their internal environment is hypertonic as a result. And so as I talk about all these things, you should be thinking about what kind of treatments would these patients need. Well, in acidosis, they need bicarb. With the dehydration, lots and lots of IV fluids, right? Keeping in mind the patient's cardiac condition history, and if I didn't mention insulin. Now, initially, the potassium levels are going to be pretty high with these patients. And so we tend to, when we give them insulin actually helps hide the potassium. Not only would it allow the glucose to go inside the cell, but it also hides potassium inside the cells as well. All right, so both. If the potassium level gets too high, we sometimes have to give them calcium gluconate, in order to protect the heart. Let's see. DKA may be seen in type 2 diabetes and conditions of severe illness or stress. And I just said that, which the pancreas cannot meet the extra demand for insulin. Precipitating factors include illness, infection, inadequate insulin dosage, undiagnosed type 1 diabetes, lack of education, understanding, and resources. So just take a look at that. With the HHS, of course, it often occurs in patients over the age of 60 years of age with type 2 diabetes, mostly, but it can, be in the other. And there's these patients are producing insulin, but not enough to prevent severe hyperglycemia and this osmotic diuresis. Sometimes the glucose environment, the extracellular environment can be so hypertonic because of all that glucose, it causes you to urinate a lot. Remember the polyuria in your patients. The glucose levels are so high, it has an osmotic diuretic effect, and that's why your patients they excrete a lot of urine, polyuria. And the reason they become hungry a lot is because, or polyphagia is because they are starving at the cellular level. The cells are not getting any glucose inside of them because of lack of insulin, and so they're starving, and so these patients become hungry. All right. As far as polydipsia, the glucose contents are so high, it's created this hypertonic environment, and so they become very thirsty, and so they drink a lot. All right, so keep that in mind. Look at the management here. I'll let you guys go ahead and take a look at this. Very easy to follow. I mean, you have to give IV fluids. You have to give short-acting insulin. Please don't ever let me see somebody choose, NPH or some intermediate long-acting insulin. You need short-acting. You need to get this glucose moving inside these cells quickly. All right. Electrolyte replacements, we know that because there's electrolyte imbalance that's going to take place as well. Mental status change, we're assessing for this. Intake and output, central venous pressure monitoring. It could be a Swan-Ganz catheter, but usually just a triple lumen catheter. We can transduce, I think the distal, is it distal? No, the proximal a line, and it can give us the CVP reading, let us know what our fluid status is. So we need to get more fluids, less fluids, and so forth. Just make sure you take a look at the rest of this information. Look at the treatment here, ensure patent airway. These patients may need oxygen, nasal cannula, or non-rebreather. Large bore IV fluids because these patients need large amounts of IV fluids. Take a look at the fluids, normal saline, until the blood pressure stabilizes because these patients are becoming more dehydrated because of all the glucose. And so therefore, the blood pressure would be lower. All right. And so the urine output, we need to look at that. That's a good indicator of a good mean arterial pressure and also hydration status. Insulin drip will be required. Take a look at the patient's history. Monitor the level of consciousness, the SAT, so the urine output and so forth. We talked about that. Always assess for the breath sounds because you're giving this patient a lot of fluids, and so they can go into fluid overload. You should know the symptoms by now. Opposite of fluid volume deficit, of course. Monitor the serum and the potassium levels. We may have to correct the potassium levels at some point because of the osmotic diuresis. Just like when you give a diuretic, you lose potassium. With the osmotic diuresis, you can at some point lose potassium as well. So you have to watch the potassium levels at some point, well, continuously rather, and you may have to replace. You may have to give sodium bicarb if the pH is lower than 7. We talked about that. Also, once the blood glucose levels get to about 250-ish, we have to hang a dextrose solution, all right, because they can go to the opposite end and become hypoglycemic. So once the blood glucose levels fall at around 250-ish, hang dextrose solution. Look at the, let's see, so HHS is a medical emergency and has a high mortality rate. That's because these patients are in severe dehydration. Like as I told you, they're not excreting the glucose as much in the urine because they have cardiac and renal compromise from getting older, and therefore, they have a much higher mortality rate. The dehydration is so much more significant in HHS. All right. So just read the rest of this information here. And testable. So you had really better look at this. I'm serious, everyone. Better really look at this. And these are just some of the manifestations of Cushing syndrome. And of course, this is probably one of your best depictions here, and I showed you this already, right? These are some of the things that you're going to note: the moon face, the increased body and facial hair. That's that hirsutism, the weight gain, the purple striae, the ecchymosis resulting from easy bruising. Remember those capillaries, because the proteins are being broken down. They have muscular weakness, the skin is thin, and of course the blood vessels are breaking, and so they have the easy bruising. The slow wound healing. Think about what I talked about, white blood cells. The immune system is compromised with Cushing's syndrome. And this is what this is. This is what Cushing syndrome will look like. Or if a patient is on synthetic steroids, they look like this, right? Look at the buffalo hump. Very important. The supraclavicular fat pad, the red cheeks, the thinning hair and whatnot. Again, you will see this in your patients with steroids. This is a very important presentation here because it is testable. I would say that, I don't know a slide on here that is not testable. So this is one you really better take a look at. Also, what I wanted to show you, I don't know if I can get to it from here before I let you go. Maybe here. I want you to make sure when you come, and we have another class day before you take your test, so you don't have to panic. We can discuss some of the other topics. But this is the PUD voiceover. So week 7 has its PowerPoints and voiceovers. I actually did a voiceover on what we just talked about today. So if you want to listen to that again or the recording from today, that's up to you. This is the presentation I just went over. These are some of the GI disorders, the liver disorders. Let's see. I click on that one. Some of these I did a voiceover on, so you can take a look at that if you want. That's peptic ulcer disease, so make sure you take a look at that. I did provide the information. Well, it's a voiceover, but I did provide information for peptic ulcer disease. The biggest problem here is bleeding, hemorrhage. It's going to be your biggest problem. So let's see, that's that. It's all peptic ulcer there. Right. Let's see, conservative treatment. So make sure you guys are reading these PowerPoints. If you want to just refer to this instead of the book, that's fine. I would just study this because guess what? This is the book. Let's see. So that peptic ulcer disease, someone told me that your CMS had a lot of peptic ulcer disease on it. So, you know, stomach cancer, I think they said it talked about some of that as well. So take a look at this. Your stomach cancer, I provided a nice piece of information about that. Let's see, stomach cancer, gastritis, upper gastrointestinal bleed. So take a look at this information as well. Again, I would just focus on this. Let's see, click to add title. I don't know why I did that. All right, anyway. Acute abdominal pain and laparotomy. This is very important because you'll get some patients that they come in with an acute abdomen which requires surgery. So take a look at this. Say acute abdomen, and then these are some of your other issues like your cirrhosis. They said there was some on there about that. Cirrhosis, acute liver failure, that's testable as well. Liver cancer, all that's testable. Liver transplant, very testable. Tell you that right now. So make sure you take a look at this. Acute pancreatitis. It's going to be very important for you to look at. And that's it. So if you guys, again, if you just want to just focus on this particular information over the weekend, of course, this other information would be on your exam as well, but this is something I would certainly make sure I take a look at before the weekend is out. So today is Thursday. Yeah, anyway. All right, folks. I kind of just felt so rushed today with these problems. All right. So that's about it. I'll see if I can get this presentation to you. I think I have to convert this to an MP4, like YouTube, and so I'll get this to you. Otherwise, you do have the voiceover that I provided for stomach cancer, gastritis, and upper GI bleed, and also PUD. Some of them don't have it, but I don't think I did it one for transplants. But you know, just take a look at it. And that's about it, folks. I'm going to go ahead and let you guys go because I need to obviously rush to this other class, and so I will send me your emails. Those of you who have not turned in your papers yet, my advice to you is to read this email I sent last night. I know some of you may not be very happy with your grade, but you know, some of you didn't address some of the elements. If you don't address an element, there was a time I would still give students credit for the elements that they didn't address, and that was not fair to the student. And so if you didn't address, let's say, a few items on there, then I couldn't give you points for it. I'll work with you, you know, if you want to go ahead and address those things. For those of you this applies, you know, I'll work with you, but I just can't give you points for something you didn't do. But also, again, I'm going to say, please stop putting introduction as a header. Introduction is a no-go. I said that time and again. If you look at the instructions that I provide for you all, especially in that email, it was in the announcements, but I also provided it in the email. That should help you out. You just have to read it, you know. Just pay attention to those details, and you would it may kind of make you upset now, but you'll appreciate it, you know, once you get to grad school in particular. You have less frustration, I promise you. Especially if you meet someone like me, because I really get you good when you come to grad school. You know, you guys I've had a little mercy on, believe it or not. Also, make sure your topic is related to the ICU. Some of those topics that you guys chose can be managed elsewhere, but there's some tools that we use are specific for the ICU. Anyway, I'm not going to rehash that. I've already spoke of that too many times. So it's up to you if you want to pay attention to that. Otherwise, you know, whatever. Anyway, see you later, guys. I will talk to you next week, or send me an email. And thank you.